Hi Rohit, am I audible? Rohit, am I audible?
Yes, sir.
Yeah, I need a help. First thing is you make me host. I'll change my name.
Yes, sir, you are audible.
Yeah, you make me host first. Yeah, wonderful. Hello, Dr. Chen. You have to unmute yourself.
Sorry, I forgot it. Yeah.
So we're just waiting for 5 minutes. Let just Professor Yoko Kato come back and then we'll start. Hello, Dr. Lin.
Hello. Hello, everyone.
Hi, hi.
Yeah,
hi.
hello. Hi. Hello, Sachin. Are you working? Are you working in the operation room?
Yeah, I just finished the case actually.
Oh, okay. Great. How's your surgery?
Yeah, it was wonderful. It was just one cauda-equina syndrome. So we had to operate as an emergency.
Okay, good.
Yes.
Yeah, that's waiting.
Maybe I can play the video for some time. So I think Professor Kato has joined. Yeah. So shall we start the program, Professor?
Yes, please.
Yes. So hello, good morning, good afternoon, and good evening to all the distinguished speakers, chairs, and audiences of ACNS YNS webinar from different parts of the world. We are back again with another session of education lectures for you to promote the neurosurgery education in low-resource countries, especially this time in Myanmar and Afghanistan. And today's episode is to encourage the education in Afghanistan and Myanmar and also to Sri Lanka. Today we have invited expert guest speakers from Japan, Professor Rakira Gomi, who is expert in pediatric brain tumor surgeries, and Professor Naoto Punni, who's known for epilepsy surgeries. Along with that, we have a young, dynamic, young neurosurgeon from South Africa, my friend Dr. Nkubail Tango. Along with that, we have our chief patron, our president, Professor Yoko Kato, our co-patron from Afghanistan, the president of Neurosurgical Society of Afghanistan, Professor Fawad Tirzad, and Professor Matthew is not able to join today. So on behalf of ACNS YNS Committee and Professor Yoko Kato, we welcome all the speakers and audiences to this educational online platform of the ACNS YNS webinar. The moderator from today, we have from the YNS Committee, our chair of ACNS YNS, Dr. Liu Bun Singh from Malaysia. We have a member of ACNS WIN Committee, Dr. Lin from Philippines. From the Fujita Alumni Association, we have Dr. Maruf from Uzbekistan. And we have Dr. Hira, who is the president of the Medical Student and the Resident Society of ACNS. So with that opening remark, I welcome all you all. And I would request Professor Yoko Kato to say a few opening encouraging message, please.
Hi, everybody. Thank you very much for Dr. Sajin making such a wonderful YNS, the monthly educational webinar. Today we have so many nice the guest speakers from Japan and also the South Africa, and also the moderator is very fantastic. So I'm so happy because Miss Hira, she will be joining us tonight. So of course, we would like to listen to your lecture. Thank you.
So with that, we will start our first lecture. May I request Dr. Lin to give a short introduction of Professor Akira Gomi, and then we'll start. Dr. Lin?
Oh, yes. Can I share my screen?
Yeah, you can share, no problem.
Okay.
Yes, yeah.
Okay, so good day, good morning, good evening, depending on where you are in the world. So I'm privileged and honored to introduce Professor Akira Gomi from Japan, who had finished his medicine from Jichi Medical University School of Medicine. He had his PhD in Jichi Medical University Graduate School of Medicine, and presently he is a professor at the Jichi Medical University, where before he became an assistant professor of Department of Neurosurgery and also served as associate professor of Department of Neurosurgery. His special interest is pediatric neurosurgery. So we would like to welcome him for his talk.
Thank you, Dr. Lim. I'm Dr. Gomi from Japan. So can I share my screen?
Yes, Professor. Please share your screen.
Can you see my screen?
Yes.
Yes, Professor.
Well, let's start. It's okay?
Yes. Please start,
Yeah.
Professor.
Yeah. Today we'll talk about surgery of pediatric brain tumors, especially posterior fossa tumors. This is our institute, Jichi Medical University, located in countryside, about 100 kilometers north of Tokyo. Our children's medical center is right next to the University General Hospital. This is a graph of the distribution of pediatric brain tumors. Pediatric brain tumors frequently occur in the posterior fossa. This data is from Japanese brain tumor registry, including children and adults. The most common tumors in the fourth ventricle are ependymomas and medulloblastoma. And this shows the data of our institute. Tumor surgery is the most common of posterior fossa surgery, and medulloblastoma and ependymoma and cerebellar astrocytoma account for 80% of them. Cerebellar astrocytoma is pathologically pilocytic astrocytoma and the representative of benign pediatric brain tumors. It usually arises from cerebellar hemisphere, and the typical radiological findings include cyst and enhancing mural nodule. The most frequent signs and symptoms are increased ICP and cerebellar ataxia. It is completely curable with resection of the enhanced lesion. Here is a pathology of pilocytic astrocytoma. A biphasic pattern of compact cells and containing Rosenthal fibers and loose textured bipolar cell with microcyte is characteristic. Medulloblastoma is representative malignant pediatric brain tumors. It usually arises from the roof of fourth ventricle and forms a Burmese tumor. 75% occur before the age of 10. Hydrocephalus is common, and most frequent signs and symptoms are increased ICP, cerebellar ataxia, and cranial nerve palsy. Recently, molecular diagnosis and classification has been developed. Mike Taylor described ependymoma cells originate from the progenitor cells. 30% occur before the age of 3. In children, 1/3 are supratentorial and 2/3 infratentorial. They have been shown to be molecularly distinct. Signs and symptoms of the posterior fossa ependymoma are similar to those of medulloblastoma. A current standard care includes maximal safe surgical resection followed by focal radiotherapy. This is a comparison of diagnostic imaging of medulloblastoma and ependymoma. Medulloblastoma appears hyperdense on non-enhanced CD and restricted diffusion non-MRI, and is enhanced by more than 90%. Ependymoma often squeeze through fourth ventricle foramina and extend into the subarachnoid space, so-called plastic. The diagnostic imaging of posterior fossa tumors, ATRT, sometimes extend into quadrigeminal cisterns, and the ependymoma appears to engulf the vertebral vaginal artery. This is a summary of comparison between medulloblastoma and ependymoma. Compared to ependymoma, medulloblastoma shows a more distinct interface to the fourth floor and is more homogeneous, and low ADC is also important. Ependymoma are more heterogeneous and show more calcification and hemorrhage than medulloblastoma. Several morphological variants of medulloblastoma are recognized: classic, desmoplastic nodular, medulloblastoma with extensive nodularity, large cell anaplastic. Molecular studies of medulloblastoma indicated that these tumors can be separated into 4 groups: Wnt activated, sonic hedgehog activated, group 3, and group 4. In WHO 2016, medulloblastoma are classified into 4 groups: Wnt activated, sonic hedgehog activated p53 mutant, sonic hedgehog activated p53 wild type, and non-Wnt, non-SHH. Furthermore, classification into 9 groups was proposed in 2017. However, WHO classification 2021, this year, is the same as 2016. This indicates that prognosis risks varies within the same group depending on age, genetic information such as p53 or like something like that, metastatic and pathological findings. This presents standard treatment regimen for medulloblastoma. Then in either regimen, St. Jude or something like that, the first step is maximum rejection. And this article discussed prognostic value of medulloblastoma extent of rejection after accounting for molecular subgroups. They said, although maximum safe surgical resection should remain the standard care, surgical removal of small residual portions of medulloblastoma is not recommended when the likelihood of neurological morbidity is high, because there is no definitive benefit to gross total resection compared with near total resection. So maximum more safe. So, in the ependymoma, important histological features of ependymomas are ependymal rosette and perivascular shoot rosette. And EMA immunoactivity can be found as dot-like perinuclear or ring-like cytoplasmic structures. Pajtla classified 500 ependymal tumors using DNA methylation profiling into 9 molecular subgroups in 2015. However, this includes subependymomas and spinal ependymoma. Intracranial ependymomas are divided into 2, supratentorial and posterior fossa, and both of which fall into the 2 groups, Lele fusion, YAP1 fusion, and PFA, PFB. And in children, most of the posterior fossa ependymomas are worse prognosis PFA. There is no standard effective chemotherapy, so the current standard of care includes maximal safe surgical resection followed by focal radiotherapy. We have to aim gross total resection because it was associated with the best overall and progression-free survival rates. From now, let's talk about surgical procedures. There are several surgical approaches to posterior fossa tumors. This shows skin incision and craniectomy. Choose a midline suboccipital approach for fourth ventricle tumor and mediolateral and unilateral for the tumor in the hemisphere and the lateral for the sleepy angle tumor. This also shows surgical approaches. This right to supracerebral infratentorial Stein approach and occipital transtentorial approach is selected for the pineal lesion tumor. Here we show the surgical position for the midline suboccipital approach. For fourth ventricle tumors, we position the patients so that we can see in a straight line from the foramen of Magendie up to the aqueduct. The surgeon stands on the left dorsal side of the patient so that head tilt to right and rotate to left. And we should understand the anatomy of nuchal muscles not to miss the midline. And we need to understand the anatomy of the fourth ventricle. This is an anatomical image for telomeral approach. When we open medullotonsillar space and uvulotonsillar space, and we can see the roof of fourth ventricle, thylakoidea telobea. Now we can enter fourth ventricle after dissecting it. And this approach was convenient to reach the fourth ventricle while avoiding vermis damage. But I'm doubt that to avoid vermis incision is equal to the cerebellar mutism. This is an anatomical image of fourth ventricle floor. Vagal triangle, hypoglossal triangle, facial collicles, an important structure. And stria medullaris points to in the direction of the foramen mollusca. Here we review cerebellar mutism. The incidence of cerebellar mutism syndrome was reported to be 24% in children who underwent medulloblastoma surgery. Significant risk factors are brainstem involvement and midline location of the tumor. The dentate thalamocortical tracts and lesions are considered significant pathological issues. I believe that damage to the dentate nucleus is sometimes due to retract during surgery. It affects the onset of cerebellar mutism rather than vermis incision. So I think small cerebellar vermis incision is acceptable. This is tips of medulloblastoma surgery. Tumors are usually soft, friable, and can be easily removed by suction aspiration. Then we can usually identify the tumor margin by color and hardness. When using the ultrasonic surgical aspirator, the surrounding subarachnoid space should be covered with cotton to prevent dissemination, surgical dissemination. The patient position is important to avoid brainstem surgery, and minimum cerebellar retraction, especially near the dentate nucleus, is necessary. This is a procedure for medulloblastoma, resection of medulloblastoma. Open the cerebellar medullary fissure, cerebellar approach, and don't hesitate small vermis incision. Identify and dissect the pica and feeding artery, identify the foramen majandi, and cover the floor of fourth ventricle with cotton. And the tumor resection with forceps, suction, aspiration with ultrasonic aspirator. Then keep the floor of fourth ventricle and reach aqueduct early and cover aqueduct with cotton. And identify the interface between the tumor and the cerebellum from lateral to dorsal. Here we show a case of 6-year-old girl. Typical findings of medulloblastoma: hyperdense on non-enhanced CD, homogeneous enhancement on the MRI, and high signal in diffusion weighted images. Here is video. The tumor protrude from the foramen of majandi, and here is a dissection of cerebellar medullary fissures. And it is internal decompression, the biopsy, it's biopsy. Here is foramen of majandi and pica. And the PSEA runs on the surface of the tumors. Internal decompression of the fly of the tumor with forceps. And raise the caudal of the tumor, we can see the striate and cover the cotton fourth ventricle. The tumor is aspirate. We can remove with aspiration. Pull out from the foramen mollusca. And we can see the aqueduct. We can, here we can see the aqueduct and covered with cotton. And dissection and remove the tumors from the surrounding structures. And the removal of residual tumor at the roof of supravermis, roof. This is after complete removal. We can remove completely. This is another case. No, thank you. This is another case. This is a 1-year-old girl. This tumor was so firm, so we need to dissect vermis. It cannot suckable, so we have to use the scissors like this. and completely removed. This is after surgery, MRI. Next, tips of ependymoma surgery. To-do list is the same of medulloblastoma. The most important point to know the plastic characteristics and to aim no residual tumors. Plastic ependymoma has already been reported in 1961. This was a report of autopsy findings of 8 ependymoma showing lateral extension. The growth characteristics tends to extend like plastic material along the contours of regional structures. It proved to be easy separate from the underlying structures. It had engulfed the vagal artery and the local nerve roots. We need to know characteristic extension. The tumor can be separate from the underlying structures. The tumor can be removed by pulling between 2 nerves or vessels. Here we show a case of 4-year-old boy. The tumor is engulfing vertebral artery. We need to carefully identify this is a vertebral artery and the boundary between the tumor and the vessels, and the tumor can be removed by carefully pulling it out. This is another case of 2-year-old boy. Remove tumor by careful dissection from between the lower cranial nerves. Yes, here is lower cranial nerves, like this. This is surgery at recurrence in the same case. Photodynamic diagnosis 5-ALA was useful in removing a recurrent tumor of the medulla oblongata. This is another case of 1-year-old girl. We can see the plastic extension. The tumor surface is smooth and identify easily the interface between the tumor and surrounding structures. In this case, we left the tumor that extend to CP angle. In some cases, simultaneous midline and lateral approach were performed. This patient is 1-year-old, so I thought it would be heavily burdened. So we removed completely with second look surgery. This is a summary of tips for resection of posterior fossa medulloblastoma and ependymoma. In the last take-home message, surgical strategies based on the anatomical and biological properties of the tumor and the effectiveness of adjuvant therapy are important. Treatment strategies considering long-term functional prognosis is also important. Finally, I hope the people of Afghanistan and Myanmar can live in safe and peace. Thank you for your attention.
Thank you. Thank you very much, Professor. That was an excellent lecture. And you tried to cover each and every aspect of pediatric brain tumor, including the recent molecular advantage and advancement. Is there any question from the panelists or from the delegates? Dr. Liu, are you there?
Yes, yes, Professor. I have a question. Yes, I just recently had a case of a patient, 15-year-old girl with a grade 4 medulloblastoma we did safe resection. I think we had some difficulty because some of the tumor was already invading the cerebellar hemisphere. We had like 10% left, so she has to undergo craniospinal irradiation, right? And also
Right.
chemotherapy.
Yes.
Is that correct? Yes. So with older patients with medulloblastoma grade 4, and if she completes the radiation and the chemotherapy, what is the prognosis for 5-year survival?
Yeah. It depends on the pathology and molecular classification. Maybe
it was large cell anaplastic.
in some cases it's very effective as adjuvant therapy, but in some cases it's not so effective. It depends on the tumor biology. So could you check the molecular characteristics or something like that?
It was large cell anaplastic.
It's not good. Yeah, it's very large cell and anaplastic type is very difficult to treat. So we have to select the severe heavy chemotherapy, including the transplantation. In Japan, we usually use high dose chemotherapy using the transplantation of peripheral blood rescue.
Okay. Thank you. I think there's another question. Somebody's raising his hand.
Yes, Professor Pirzad. Welcome, Professor Pirzad.
Okay, hello. Good afternoon. Konnichiwa.
Konnichiwa.
Thank you, Professor Akira Gumi. Thank you very much. Thank you for your best wishes and hope for Afghanistan. Thank you very much. And also, good afternoon for everyone and for Professor Kato and Sachin. Thank you very much. What is your advice for patients with posterior fossa tumor and obstructive hydrocephalus? Do you think that we put first shunt, then operated on the tumor, or at the same time is it possible to reduce the ICP? Thank you.
Yeah, it's a good question. That's a very important point. Yeah, in a hospital we can do the tumor surgery immediately, so we don't need to the drainage and or VP shunt or something that just do the removal of a tumor. So it's a procedure. We can treat the hydrocephalus simultaneously, but in some cases, maybe the tumor removal is not to do immediately, can be done immediately. In the case of the some people use endoscopic third ventriculostomy to treat the hydrocephalus before the tumor removal. But I have no experience of the ETV before the tumor surgery. The simple drainage, continuous drainage is sometimes risky because it causes upward herniation. It's okay?
Arigato. Arigato.
Professor Gomi, thank you very much for a nice presentation.
Thank you.
Thank you so much. So just I want to ask, do you sometimes use the endoscopic procedure, the pure endoscopic resection of the tumor, because the tumor itself is quite soft?
Yeah,
so,
I don't use the endoscopic removal of a tumor, but in the future, it's possible, maybe. Yes.
Okay, thanks a lot. Nice video, nice surgery. Thank you very much.
Thank you very much.
Thank you very much, Professor Gumi. May I ask a question? So in case of most of the posterior fossa surgeries, including ependymoma and medulloblastoma. Sometimes some of our patients has developed cerebellar mutism. Can you tell us maybe some tips or tricks? How do we avoid having this cerebellar mutism? Maybe any surgical step or anything, or any particular thing, sir?
Yeah, cerebellar mutism, the cause of cerebellar mutism is various reasons. It's yeah, in the past, the Barmian split caused cerebellar mutism, but I don't think it. In my cases, I have some cerebellar mutism patient, but usually it's depends due to the dentate nucleus damage after the hemorrhage or retraction or something like that. So in the surgical procedure, we have to care not to retract the heart of the roof of the fourth ventricle to prevent damage of dentate nucleus. This is my procedure. It's okay.
Thank you very much, Professor. Any other question from the panelists? Dr. Aaron is there. He's one of the Fujita alumni from Zimbabwe, right? Hello, Dr. Aaron. How are you?
I'm well, thank you. My question is, do you regularly use a frozen section to differentiate between the medulloblastoma and ependymoma intraop, so that you can decide in terms of how much aggressiveness you can go for? Thank you.
Thank you. It's a good question. I use, of course, I use frozen section during the surgery to differentiate the medulloblastoma and the ependymoma. If it's medulloblastoma, I try to complete resection, but it allows a little bit residual because it can be treated with the adjuvant chemotherapy. But in the ependymoma cases, only radiotherapy is only effective, but not chemotherapy is not effective. So we have to remove completely in the case of ependymoma. So we decide during surgery from the result of the frozen section. It's okay.
Yes, thank you. Thank you very much, Professor. And thank you, Dr. Aaron, for the participating. Is there any other question from the panelists? You're muted, Professor. Professor Yoko Kato, you're muted.
Oh, sorry. So you can tell us what about the geographically the distribution of the tumor? Because in Japan we have getting less and less of the medulloblastoma. So can you tell us, please?
Yeah. How about the other panelists? I don't know much about that.
Okay, no problem.
Some infectious cause. Some infectious cause, or I'm not sure, but just
That's I don't know. It's infectious cause. I think it's not good. No relevant to the infectious causes.
Thank you.
Thank you. Dr. Chaitan, are you aware of any geographical variations of the pediatric brain tumors, since you deal with a lot of pediatric brain tumors?
Yeah. Thank you, Dr. Gomi. That's a very wonderful presentation. Actually, I have no any questions. In China, we have many NGS company, and after surgery, we also do the sequencing DNA sequencing or RNA sequencing. How is the developer of the genomic test in Japan? Many company or only several company? And do you use RNA and DNA mutual sequencing?
Yeah,
we want to find we want to find the immunotherapy biomarker.
It's important problem. In Japan, the DNA and the RNA sequence is only by the research company, research institute volunteer.
Oh, okay.
No official company.
Okay.
No official company for the DNA RNA sequences. So we send the specimen to the Osaka Institute of and the doctor of Osaka do all of Japanese specimen, correct and check the RNA and the DNA. So
Okay.
it's
I see.
it's a research.
It's research.
Yes.
Okay. So the patient didn't pay anything for the NGS sequencing test. It's free, it's me.
Yes, free, but our group, Japanese Children's Cancer Group, gets the money from the government and distribute to the research center.
Okay. In China, most of patients' sample were sent to the institute, the commercial institute. This is business. Patient have to pay for the test and receive the result. But some of part of institute and research colleague university, we also to do that's free for research, only for research. Okay. And do you have by bank, the sample bank in Japan?
Yes. But it's I don't know much about this.
Yeah. Okay. And I heard you said you have to send a sample to Osaka, right?
Yes.
So it's a long way. It's a very long way. How do you keep the sample in the frozen?
In the frozen.
Logistic link.
Yes.
Okay, I see. Yeah, we would like to make more community in this field in the future.
Yeah.
Thank you.
Yes. Thank you very much.
Thank you.
Thank you very much, Dr. Chen. As always, thank you for the enthusiastic participation. Is there any question from the panelists? Okay, then we'll move on to the next speaker, and maybe after that we can come back to the questions if anybody has.
I have a little question.
Yes. Dr. Andruska, please go ahead. Please introduce yourself and then ask the question.
Yeah, sir, I'm Alexander Andruska from Republic of Moldova. I have one little question, what I'm stumbled upon. It's, sometimes child that underwent surgery in the posterior fossa has some postoperative blindness. What do you think it's related to and how to avoid this, besides the mutism?
Oh, blindness. Yeah. I don't know what postoperative blindness after the posterior surgery.
Yes, exactly. Temporarily blindness, like for 2-3 days.
It's due to the I don't know. It's due to the increase in INCP, the intracranial pressure increase to cause an optic nerve injury or something like that. It's I don't know.
Okay. Thank you very much.
So thank you very much. Maybe, I don't know whether I'm correct or not, but sometimes because of the drop in the blood pressure, patients do develop transiently something like Press syndrome, which is posterior reversible sort of encephalopathy syndrome, which is reversible. Generally, it comes back after 24 to 48 hours. That's what we have seen in one of our patients who actually had a blindness. We're not sure whether it was just a cortical blindness or not, but it reversed after the 24 hours. So that could be one of the reasons.
Okay.
Yes.
Thank
Thank
you.
you.
Thank you. Comment.
Yes. Yes. Any other question from the panelists? Okay, then we'll move on to the next speaker. May I request Dr. Maruf, who's from Uzbekistan and who's the member of Fujita Alumni Association, to give a short introduction of Professor Naota Kuni, please. Dr. Maruf, can you unmute yourself?
Good evening, good afternoon, dear professors, dear colleagues. So, Naota Kuni.
Little louder, you're not audible.
Okay.
Dr. Maruf?
Yes, yes.
Yeah, little louder, you are not audible. Dr. Liu, are you there?
Yes, Sachin. Yeah.
Yeah, maybe Dr. Liu, you want to do it for him? Just a short introduction.
Okay. Or I think Maruf, you take out your the headset, remove your headset and talk. Remove your headset from the computer and yes, take out your headset from the computer and you try to speak again.
Hello, everybody.
Yeah.
Yeah.
Yeah,
Yes, it's
you're
good.
audible.
Good. Yeah. Yeah.
Please go ahead.
Prof. Naota Kuni, MD degree, Faculty of Medicine, University of Tokyo, and PhD degree, Graduate School of Medicine, University of Tokyo, and residency in neurosurgery, Gunma University Hospital and the University of Tokyo Hospital. Current position, Assistant Professor, Department of Neurosurgery, the University of Tokyo. Director of Epilepsy Center, the University of Tokyo Hospital. Special interest in epilepsy surgeries.
Thank you. Thank you very much, Dr. Maruf, for the short introduction. Now over to you, Professor Naota. Can you share your screen, please?
Yeah. Can you hear me?
Yes, we can hear you, Professor.
Yeah. Okay. And can you see my slide? Okay.
Yes, it's visible.
Yeah. Thank you for kind introduction, Dr. Maruf. It's a great honor for me to have an opportunity to speak at this excellent webinar. Today, I'd like to talk about epilepsy surgery. Actually, I don't know how many of you are familiar with epilepsy surgery, but at least there are quite a number of patients who will receive great benefits from epilepsy surgery. So I'm happy to have an opportunity to share with you such cases and interesting aspects of epilepsy surgery. Okay, so when should we consider epilepsy surgery? As you know, epilepsy is a neurological disease which responds to medical treatments very well. In addition, there are an increasing number of new anti-epileptic drugs which can be used in various combinations with fewer side effects. So is there any room for epilepsy surgery? This is a well-known study which showed the proportion of patients responding to the first, second, and third or more anti-epileptic drugs. As you can see, almost half of the patients are expected to respond to the first drug, but only 13% of the patients will respond to the second drug, and only 4% to the third or multiple drugs. So this means more than 30% of patients are drug resistant. Based on such evidences, drug resistant epilepsy is defined as failure of two anti-epileptic drugs to achieve sustained seizure freedom. Here, sustained interval usually means about 1 year. So for the patients with drug-resistant epilepsy like this, surgical treatment is considered. So these are the indications for standard epilepsy surgery. I'm explaining each of these surgical procedures. Sorry. So let's start with the first one, regional focal epilepsy. For regional focal epilepsy, focus resection can be performed without investigation of using intracranial electrodes. Just focus resection is possible. These are representative MRI lesions, which could cause drug-resistant epilepsy. Hippocampal sclerosis is a major cause of temporal lobe epilepsy, the most frequent cause of partial epilepsy or focal epilepsy. As you can see, the left hippocampus is atrophic compared to the right hippocampus, and layer structure within the hippocampus can't be seen. And cavernous malformation is also a major cause of epilepsy. And various brain tumors such as ganglioglioma, and DNT are also epileptogenic lesions. And congenital abnormalities such as focal cortical dysplasia is an important target of epilepsy surgery. From epilepsy surgical point of view, the most important anatomical part of the brain is the temporal lobe because it contains the hippocampus. This is a gross anatomy of the left temporal lobe, the coronal section. You can see the hippocampus here, located on the parahippocampal gyrus, separated by the hippocampus sulcus. And the amygdala makes the roof of the inferior horn of the lateral ventricle, and the amygdala is confronting to the hippocampal head like this. Importantly, the optic radiation surrounds the inferior horn like this. So how do we approach to the major temporal lobe with minimal damage to the optic radiation? So there are various approaches to the medial temporal lobe. In Spencer's approach, anterolateral part of the temporal lobe is resected. Trans-Sylvian and Trans-T1 approaches were developed to preserve lateral temporal lobe function, especially in the language dominant side. The drawback of these three approaches is partial damage to the optic radiation, or Meyer's loop, as you know, which results in homonymous superior quadrant anopsia. But these two approaches are free from this drawback, the damage to the optic radiation, but subtemporal approach and supracerebral transtensory approach. But due to some technical complexity, these two approaches are not so widely used. And one of the most frequent asked questions about these approaches is how to find the inferior horn in the white matter of the temporal stem. As shown in this schema, blood flow in the deep white matter is drained through medullary veins to the ependymal vein. So tracking the medullary vein in an axial direction would lead you to the inferior ventricle. So I'm introducing a procedure of Trans-Sylvian selective amygdala hippocampectomy. This procedure is applied in cases with localized epileptic focus within the medial temporal lobe, especially in the language dominant hemisphere. In this procedure, first you approach to the inferior limiting sulcus of the insula via Sylvian fissure. Of course, you can go there transcortically through T1 or T2. And you can find the inferior horn by keeping your microscope direction 45 degrees to the brain surface. The amygdala is partially resected. This is the view from the top. You continue suctioning the brain tissue, that is the ANCAS, and find the pia mater through which you can see the ICC stem. Here are P2 portion of PCA and the anterior choroidal artery. And the anterior choroidal artery enters into the inferior horn here. Then you cut the hippocampus laterally and posteriorly. Finally, you cut the hippocampal arteries within the hippocampal sulcus and remove subpially the hippocampus and parahippocampal gyrus in an unblocked manner. Okay, this is a video of this procedure. This is a case of left hippocampal sclerosis, the left frontal lobe and temporal lobe. Left Sylvian fissure is opened until inferior limiting sulcus is found. So approximately 2 centimeters of corticotomy is made along the inferior limiting sulcus. The hippocampal surface appears in the inferior horn. After the ANCAS is resected, you can see the cerebral peduncle through pia mater. Posterior to the ANCAS, the choroidal fissure is confirmed. Then the hippocampus is resected laterally and posteriorly. This is the posterior margin of the resection. Then returning to the medial part, the hippocampal sulcus is opened. The hippocampus artery is coagulated. These are very atrophic hippocampal arteries. They are coagulated and cut on the surface of the parahippocampal gyrus. Then you can dissect the parahippocampal gyrus subphially. Finally, you can remove the hippocampus and parahippocampal gyrus in unblocked manner. After removing the hippocampal complex, you can see the oculomotor nerve, PCA, SCA, and cerebral peduncle. Okay, this is 32-year-old female was presented with weakly impaired awareness seizures, which were drug resistant. And she had childbearing desire and decided to undergo surgery. As you know, the blood fluid should be avoided in female cases of childbearing age. MRI showed the right hippocampal sclerosis, as you can see here. And the FDG PET showed hypermetabolism in the right major temporal lobe. It was suspected that her language dominant side was right in this case. So therefore, we performed right selective amygdala hippocampectomy. This is a post-operative MRI, and she became seizure-free, and the anti-epileptic drugs were terminated. Okay, next is non-lesional MRI negative epilepsy. In these cases, we need to implant intracranial electrodes to determine epileptic focus before resective surgery. This is a 43-year-old female who was diagnosed with epilepsy at 20 years old. After giving birth to her first child, her seizure control became poor. She had generalized tonic-clonic seizures every month and couldn't continue her work. And MRI showed no obvious lesion, which can explain her epilepsy. However, electroencephalography indicated persistent epileptic activity in the right frontal lobe like this. And also you can see FDG PET showed diffuse hypermetabolism of the right frontal lobe. So in this case, right frontal lobe epilepsy was suspected. And in this case, we implanted intracranial electrodes covering widely the right frontal lobe. As a result, we detected seizures originating from the anterior part of the right frontal lobe. So we performed frontal disconnection like this. The frontal lobe has a complicated network connected to the whole brain, and it is sometimes difficult to resect epileptic focus completely. So in frontal lobe epilepsy cases, this connection is more preferred than resecting a large part of brain. And after the surgery, she became seizure-free, and as I showed here, neuropsychological scores had drastically improved. Okay, let's move on to epilepsy due to hemispheric pathology. In such cases, hemispherotomy is considered. This case was 1 year and 4 months old infant. He suffered from acute subdural hemorrhage caused by abusive head trauma, which resulted in acute encephalopathy with convulsive status epilepticus. And at 7 months old, generalized tonic-clonic seizure started. And following that, he developed daily seizures, very frequent seizures. And multiple AEDs anti-epileptic drugs failed to control his seizures. At 7 months, his left hemisphere is very atrophic like this. And FDG PET showed severe hypermetabolism of the left hemisphere. And by checking electroencephalography, we confirmed his seizures originated from the left hemisphere and went on to hemispherotomy. In hemispherotomy, you need to cut all the commissural fibers like corpus callosum and anterior commissures, and also projection fibers like internal capsule. You don't need to cut association fibers, which connect cortical parts of the brain. This illustrates the procedures of vertical approach of hemispherotomy. First, you perform callosotomy via the interhemispheric fissure. Then go into the lateral ventricle and find the stria terminalis, which is the lateral margin of the thalamus. Following the stria terminalis posteriorly, you'll find the trigone of the fourth of the lateral ventricle. And here you can see two lines. One is the stria terminalis and the other is inferior horn. You cut the plane made by these two lines anteriorly like this. And finally, the uncus and the frontal base along this line, you disconnect the uncus and the frontal base along this line, and you complete hemispherotomy. This MRI is just after the surgery, and this is 9 months after that. As you can see, the right hemisphere is enlarged over the midline. After surgery, he became seizure-free and started to develop at a natural pace. Currently, he is 3 years old. All anti-epileptic drugs were finished, and he can speak 2-word sentences, and he can run freely. It's very important to perform epilepsy surgery, especially for children, concerning brain development. Okay, the fourth seizure type is drop attack. Actually, drop attack is a generic term for various types of seizures that makes patients fall. the patients fall suddenly because bilateral hemispheres are involved in the seizure activity at the same time, or a very short moment. Therefore, corpus callosotomy has a great effect on this type of seizure. Corpus callosotomy is curative for drop attack and palliative for other type of seizures like epileptic spasms or tonic seizures. And some patients develop mutism in acute phase after surgery, which will usually disappear in 2 to 3 weeks. And in chronic stage, disconnection syndrome sometimes occurs in patients over 10 years old. So in such cases, patients lose coordination between left and right movements, and sometimes one hand interferes with the movements of the opposite hand, as known as alien hands. Therefore, anterior third or 4/5 callosotomy is recommended in patients older than 10 years old. And also there are a few cases where you find epileptic discharges lateralized to a hemisphere after callosotomy. In such cases, there might be a chance to go on to a resective surgery for the localized epileptic focus. So let's see the movie. Small corner skin incision is made. I think you can make it smaller than this. And small craniotomy is performed over superior sagittal sinus. In this case, right dominant craniotomy is performed. Dissecting interhemispheric fissure, you can see corpus callosum like this. And suctioning the callosum, you can find the cavity of the septum pellucidum, this one, and which is a landmark of the midline. As long as you follow this cavity, you will not lose the midline. This is the genu of the callosum. You can recognize the shape of the cross section of the genu of the corpus callosum. Then posteriorly, you do the same procedure, keeping in mind not to lose the midline. You can see the velum interpositum and bilateral fornices through the arachnoid membrane. Now the splenium of the callosum is being suctioned. And now the splenium of the callosum is being suctioned, and finally the whole callosum was completely disconnected. Okay, so this is the last part. Vagus nerve stimulation can be used for the rest of the epilepsy syndromes. VNS is a palliative treatment without craniotomy. The pulse generator is implanted subcutaneously in the chest, and a helical electrode is wound around the vagus nerve. This is the vagus nerve, and the helical electrodes are wound around it. And whereas implantation is very minimally invasive and takes only 1 or 2 hours for this procedure, and patient's recovery is excellent. And this is a seizure outcome of Japanese post-marketing survey. All patients were followed. And it's known that the efficacy of VNS is increased in the first 2 years, and it remains the same afterwards. About 60% of patients will have seizure reduction of 50% or more. So this is the last slide of my talk. I introduced epilepsy surgery for different epilepsy cases. As I mentioned at the beginning of my talk, epilepsy damages quality of life for a long period of time. Of course, the first step of treatment of epilepsy is anti-epileptic drugs. But I want you to know that these epilepsy surgeries can sometimes drastically improve the patient's lives. Thank you for your attention.
Thank you. Thank you very much, Professor, for an excellent presentation and covering almost all the aspects of epilepsy surgery. Any question from the panelist? Anybody with any special training? That's a problem with the epilepsy surgery. Yes, Professor Pizzar, please go ahead.
Yes, okay, thank you very much. Thank you, Professor Natu Kuni, for nice presentation. What's your advice for post surgery? Do we continue the anti-epileptic treatment or not?
Yeah, thank you very much. It's important issue. We usually continue the anti-epileptic drugs at least 6 months after surgery. Because the period after the surgery, we could have seizures related to the surgery. So we continued the anti-epileptic drugs after surgery at least 6 months. And if the patient had no seizure during this time or period, we start reducing the anti-epileptic drugs gradually. Thank you.
Thank you, Professor. Yes, Dr. Hemanta, please unmute yourself, introduce yourself and ask your question.
Thank you, Professor, for that excellent talk. Actually, it's very helpful for us. I'm Dr. Hemanta from Sri Lanka. Actually, in Sri Lanka, we are doing very limited number of epilepsy surgeries. Regarding these lesional epilepsy surgeries for mesial temporal sclerosis, so one of the complications we have encountered is the memory impairment. So what are the strategies you are taking to prevent that?
Thank you very much. It's also very major issue of this surgery. And yeah, actually some patients experience memory impairment after surgery in temporal lobe epilepsy cases. And so the most important thing is the language dominant side. So if we perform the hippocampectomy of the language dominant side, the risk of memory impairment is become higher. And in such cases, we use hippocampal transection. Multiple hippocampal transection. I couldn't share the video of the procedure today. I didn't prepare it, but we use multiple hippocampal transection. By transect the hippocampus, we can reduce the epileptic activity of the hippocampus, but without reducing the memory function. And yeah, this multiple hippocampal transection technique originated from Japan. Dr. Shimizu, a very famous neurosurgeon in Japan, developed this technique. And so we sometimes use this technique for patients with higher risk of memory impairment after surgery. Thank you.
Thank you very much, sir. Thank you.
Thank you, Professor. Yes, Dr. Lin, please go ahead.
Yes, thank you so much for the excellent talk. I learned so much from your talk on epilepsy surgery. May I ask if there are certain age recommendations for which you would perform the different types of epilepsy surgery? One, and two, how about post? We have a lot of cases of TB meningitis here in the Philippines, and sometimes a lot of them would be dependent on anticonvulsants for life. So And yet some also would still be resistant to some anti-epileptic drugs. So do you have any experience on this post-infectious epilepsies? Thank you.
Yeah, thank you very much. Yes, very good question. Yeah, infectious disease, epilepsy caused by the such etiology is difficult to treat using epilepsy surgery. And if we localize the epileptic focus, even in such cases, we sometimes go on to the focus resection. Sometimes we use intracranial electrodes to localize the epileptic focus, but it's difficult to treat. It's difficult to achieve seizure freedom in these cases. So if the epileptic focus is multiple or very extended cases, we use vagus nerve stimulation. As I mentioned in my talk, the vagus nerve stimulation can be applied in most epilepsy cases, but it's the effect is palliative. So if we can do the curative surgery, we should do the resective surgery first. But if it's difficult, we vagus nerve stimulation is very good option. Thank you. Thank you very much.
Thank you. Thank you very much, Professor. Thank you very much, Dr. Lin. Professor, I have a question. I've got two questions. What is your experience on deep brain stimulation in case of epilepsy? Do you perform any deep brain surgeries, deep brain stimulation surgeries, functional surgeries for epilepsies? And what about multiple pile transaction? Like you mentioned about the hippocampal transaction, but in case of a dominant hemisphere, do you perform this multiple subpile transaction? And do you perform the WADA test? Because you mentioned one case about the left cerebral hemispherectomy. So in case of left cerebral hemispherectomy, do you, as a part of the protocol because of the medical legal issues, do you perform the WADA test regularly, or how do you go about it? Thank you, Professor.
Thank you. Thank you very much. The first question, deep brain stimulation. Unfortunately, in Japan, the DBS for epilepsy has not been approved. Yeah, so the insurance has not covered it yet. So I have no experience of DBS for epilepsy cases. I think in near future, DBS will be introduced for epilepsy in Japan. And about multiple subpile transaction, of course, I perform multiple subpile transaction or MST for the lateral cortices with some functions like language function and motor areas. Yes, we sometimes perform multiple subpile transaction, and the concept of multiple hippocampal transaction is originated from the MST. Thank you. And the last question, WADA test for the hemispherotomy patients. And most cases of hemispherotomy patients doesn't have viable function of the hemisphere. The cause of the epilepsy is sometimes stroke, hemispheric stroke, or head trauma, and also the congenital developmental disease. So most of the cases lost their function almost completely, hemispheric function. And we can confirm the loss of function by referring to the FDG PET, which will show the very high metabolism, hemispheric high metabolism. And many patients have also severe to moderate hemparesis. In some cases, very mild hemparesis. But in these cases with very limited function in the hemisphere, the patients, the motor function is covered by the contralateral hemisphere. So we can perform hemispherotomy without performing water test. Thank you.
Thank you very much, Professor. Is there any other question from the panelists? Okay, if not, then we'll go ahead with the next talk, and then we'll come back to question and answer session at the last if anybody has any. So our next speaker is the YNS speaker. So allow me to introduce one of my dearest friend, Dr. Nkubail Tango from South Africa. She's done her pediatric neurosurgeon fellowship at Red Cross Children's Hospital, and she's working there. And she's a lecturer at the University of Cape Town. She's got a special interest in multimodality monitoring of injured brain and global surgery. She's also a committee member of Young African Neurosurgeon Forum and WFNS Young Neurosurgeon Forum. And she's going to talk us about craniopharyngioma, pediatric craniopharyngioma. Thank you. Over to you, Dr. Tango.
Sachin, thank you so much for the introduction, and you're a dear friend, and we work quite closely with the WFNS, so it's a pleasure to be here. I'm just going to start sharing my screen, and I'll just be ending things lightly with the clinical case of a craniopharyngioma. Let's start the presentation. Okay, I hope my slides project. As mentioned, I am a pediatric neurosurgeon from Cape Town, and I'm presenting a condition which we see quite commonly. So just to start off with, pediatric neurosurgery at the University of Cape Town, we practice out of the Red Cross Children's Hospital. We currently have 4 consultants, 1 fellow and 3 residents. And for those who don't know, South Africa is the most southernest tip of Africa. And just above us, we've got Zimbabwe, where Dr. Aaron Musar is from. So we also work quite closely with them. The reason I've chosen this clinical case is because it encompasses the fact that craniopharyngiomas require a multidisciplinary approach. And although the tumors are benign and they've got a survival of greater than 90%, they almost behave in children like a malignancy due to the recurrence and also the effects of our treatment. To just give a bit of a background, within our institution, craniopharyngiomas are actually the 3rd most common tumor we see. It's followed by our most common are posterior fossa tumors, specifically astrocytomas and medulloblastomas. Another interesting different fact for us in South Africa, maybe versus Asia, is that the pineal region tumors we see tend to be non-germ cells, so we seem to see pineal blastomas most commonly. So in our institution, the median age of presentation is 7 years of age. And as many of you know, South Africa is one of the most unequal societies in the world. So a lot of our patients present with large tumors and in quite advanced stages of disease. So we commonly see that our patients, over half of them come with headaches, visual deterioration, but close to 50% come with raised intracranial pressure and mainly hydrocephalus. And then, as known, also endocrine pathologies like growth hormone. So to start off this case that I'm going to be discussing, it's of an 11-year-old female who came through to us, was in grade 7 at school and doing well. And then the mom describes a 3-week history of headaches. And then on the day of presentation, she was having nausea and vomiting and very drowsy. We scored her GCS at 14. And also in terms of a hormone profile, she had cortisol insufficiency, and also she was short in stature and had growth hormone deficiency. And for those who can see, whenever a child in our institution comes in with a decreased GCS, we tend to start off with a CT scan because that's what's mostly available. And one can appreciate that this child had firstly acute hydrocephalus and this multicystic lesion with also solid components, which was a craniopharyngioma. So as many of us know that treats craniopharyngiomas, and specifically in children, they tend to be more cystic. But this child was a bit unique for us because there was quite a solid component. If they're cystic, we tend to put a Meyer reservoirs and use interferon. In this case, given the fact that there was quite a large solid component of it, we continued to do firstly an emergency external ventricular drain, which was done at night by the residents. We do not operate on tumors as an emergency. We always do them electively on our next available elective slate. So at night, we do urgent CSF diversion, and then the next day is on an elective slate we operate. We chose to do a near total resection here where we went subfrontal, and our main aim was to just decrease the amount of the cyst and also decrease that solid component, because the next step for this child would be radiotherapy. We also, after treatment, the child ended up having to actually have a shunt, so required permanent CSF diversion. And then we sent her across for radiotherapy. So what differentiates children's craniopharyngiomas versus adults is, as I've mentioned, they're mainly cystic and they're quite difficult to treat. This is actually a nice study that came out from the India group looking at their long-term outcomes of maximal safe resection. And they were able to get a growth total resection of 43.2%. So in children, it's quite hard because of the fact that the cyst is adherent to the surrounding vascular structures. It's really rare where we can get growth total resection, even though that's ideal. But we know in adults, and a series actually was released from Japan where they were able to get impressive results. And what's the movements currently is that we tend to lean more to subtotal or near total resection, so the maximum safe resection, and then send them off for radiotherapy. Another interesting study that came out of the US group was just looking at the 5-year progression-free survival rates. And what was interesting to see is that with them, growth total resection had similar rates to cyst decompression and radiotherapy. And then obviously in their series, they had less progression with children that had near maximum resection and then proceeded to radiotherapy. So our patients, while receiving radiotherapy, defaulted medication. And when we spoke to the mom, it seems that the child was experiencing difficulty in swallowing, and she presented to us quite sick. She was septic, also had quite bad endocrine dysfunction, as one can see her results here. I mean, her cortisol was 53. She also had DI, which was uncontrolled. During the early phase of her radiotherapy, she became symptomatic and developed DI, so she was on treatment for that. And then she also had sepsis, platelets of 40, and she had a spontaneous bleed. But what's interesting to note, though, is that this child did have mild hygromas previously, most likely due to overshunt drainage. So what pushed her over the head edge was the platelets. When she arrived to us, she had a very low GCS, and we had to intubate. Due to the fact that she had renal derangement, we couldn't give contrast. So the MRI we did, one can appreciate that there was cyst expansion. And this is quite a common phenomenon that in children, when they're receiving radiotherapy, approximately 40% of them do get the cyst reoccurrence. How we chose to manage it is that we did a retrosigmoid approach, and we placed in a Meyer reservoir, and then she was for drainage, and we were able to get her off the ventilator, and she's still currently in our ward actually getting her endocrinopathies sorted out. Another interesting fact is with our cystic cranios, as I've mentioned, we use a Meyer reservoirs, but we are now having a shortage of interferon, which is quite a huge problem. So I'm just also interested to hear from the rest of the panel whether there's any other countries that are experiencing this. And thank you so much. We look forward to welcoming you to sunny Cape Town in 2023. And thank you for inviting me, Sachin.
Thank you very much. I'm very, very glad that you've come up with this case discussion, because I would say craniopharyngioma, I would call it a benign malignancy. Although it's a benign tumor, but it is as deadly as malignant tumor. So without losing any more time, I think I will go ahead and ask Dr. Gomi, what is your opinion? I think the questions to be discussed today is, in case of craniopharyngioma, do you directly go for the shunt or you do an emergency ventriculostomy? One point. Second point, what is the best approach? Is it endoscopic or is it transcranial? Especially in this case, you see the calcified part is sitting just bang in front of the sella. It will be very difficult. So what is the best approach, endoscopic or transcranial? In case of transcranial, what we have noted is always the optic nerves are very short, and that optico-interoptic corridor and optico-carotid corridor is very, very small. So how do you deal with that? And the last question, do you routinely, is it a good practice to put the Ommaya reservoir in the surgical cavity routinely? So Professor Arika Gomi, please tell us about that.
Thank you. I'm very interesting cases. I see the first question, the drainage, and the second question is, I'd like to answer the second question first. In Japan, we can select a transcranial approach and a transnasal approach, but in my institute, I have not yet introduced the endonasal approach. So we choose for the craniopharyngioma always a transcranial approach, usually used from the interhemispheric anterior interhemispheric translaminar terminalis approach. And in that cases, I try to remove completely from the anterior interhemispheric approach. Ommaya reservoir, in some cases, large cystic craniopharyngioma, I seldom use an Ommaya reservoir, but for the craniopharyngioma, most important point is the first surgery, first attack. We have to do complete removal at the first attack. It's difficult to treat in the recurrent cases. So maybe at first question of the hydrocephalus used. Maybe in that case, if the cyst goes up to the third ventricle and cause, in the case of cyst cause hydrocephalus, we choose first ventricular drainage and simultaneously endoscopic the cyst puncture or endoscopic drainage for the cyst via Ommaya. But next step we select the tumor removal by the craniotomy. It's okay. This is my opinion. Thank you.
Thank you very much, Professor. Anybody has any question? Yes, Dr. Masawe, please introduce yourself and ask a question. You unmute yourself first.
I'm Sylvia Masawe, critical care nurse from Tanzania. Thank you, Professor, for your nice presentation. But you have seen several patients, most of them kids, with the recurrent VP shunt blockage, despite the Ommaya reservoir, due to tumor residue something. Can you tell something about that, Professor? Thank you.
Okay, thanks. I'm a doctor, not a professor yet, but thank you. From our experience, obviously the proteineous fluid is quite thick. So if we do have a cystic craniopharyngioma and we put in a Ommaya reservoir, we try and make sure that our hole is narrow so there isn't any cyst spillage into the surrounding CSF space. And with that, we've been fortunate that we don't see a lot of shunt blockages if the child ends up having a shunt along with the Ommaya reservoir. One of my thoughts is maybe just the escape of that proteineous fluid into that CSF ventricular space can actually increase the protein and possibly possibly block the shunt, but I'll also be interested to see what the rest of the panel says. So we tend to try, if we go endoscopic, when we do an Ommaya reservoir, we go endoscopically and make sure that we have a small hole to just try limit the amount of cyst contamination into the ventricle surrounding tissue. But it'll be interesting to see what the rest of the panel thinks.
Anybody else want to take that question? Dr. Lin, are you there?
Yes, sorry. Yeah, in my experience with putting in Ommaya shunts, for example, if okay, so patient presents, for example, with hydrocephalus, and then you also have cyst, and then there's calcified solid tumor also at the base, near the cella. So we usually do is that, of course, we put in, if the solid tumor is deemed to be smaller than the cyst, and it may be hard to remove completely, it's usually adherent, then we put in an Ommaya and also put in a shunt. So as Dr. Rubile said, it should be a very small enough hole so that there will be no leakage in the ventricular area. So, and then we continue aspirating the cyst to also reduce it. But we need to project also that as the cyst reduces, the shunt should always be inside the cyst of the craniopharyngioma.
Thank you, Dr. Lin. Any other comments from any panelists? So what technique do you routinely use to put this Ommaya? Like this case had come later after the first surgery, and you put it endoscopically, right?
Oh no, so for this case, when they came in with that posterior fossa cyst, the option is we either do it endoscopically or we do it stereotactic. But with this case, I actually just did a small retrosigmoid craniotomy and ultrasound, and then did it under ultrasound guidance. So it just depends where the pathology is. We tend to go endoscopic, or we use stereotactic with the neuronavigation. Those are the two we commonly use. This case, I just used an ultrasound just because it was more quicker. Yeah.
Yes. Thank you very much. Any other comments from any panelist? Dr. Chen, what is your opinion about craniopharyngioma?
About the cyst formation after radiation, to me, few cases, or in my memory, we never have had such case. Interestingly, to craniopharyngioma, there are two types of pathology. One is CP, and another is AD. To CP, most of percent it's a BRAF mutation. As I know, in Boston, Massachusetts General Hospital, they had a clinical trial. They used Velafuni. Velafuni is a targeted drug, anti the BRAF mutation. They performed it in the adult patient with craniopharyngioma, because the case recurrent again and again every several months. So after they used the Velafuni, this disease can control very well. The tumor never come back, keep a long time, almost 1 or 2 years. I will share this paper to you. So maybe you can try to use the Velafuni. It's a targeted drug. In such case, this is the in marketing cell drug, Velafuni. But to AD type, almost as I know, there is no targeted drug can use. In our experience, after the how to say, in Chinese, we like to use craniotomy, that's open surgery to resect the tumor. But as I know, in Americans, they like to use endoscope. Maybe in the endoscope, the space is limited and the tumors, how to say, the cellular tumor is not easy to remove totally. So if you have the residual tumor cell in the tumor lesion, the tumor will come back again. So importantly, in the first surgery, to our experience, remove the tumor totally is very important. Don't keep any tumor, cellular tumor, and residual tumor. It's very dangerous. That's all. Thank you.
Thank you very much.
Yeah.
Any other comments from the panelists? Yes, Professor Pirzad.
Yes, thank you very much for a nice presentation. And what about rapidity after surgery? Do you recommend it?
What about?
Yes, for us, if the children are old enough, so what we tend to do is, obviously we tend to have a lot of large cysts, so we tie them over with an amide reservoir interferon until they can go for radiotherapy. Our radiation oncologists tend to use protein beam therapy. That's something that gets done by them. So that's what this child actually got. Our children, even though we haven't published yet, tend to get a good outcome on that, but we still need to look at our progression-free survival before we can comment confidently. But in terms of radiosurgery, that region, we do not perform it within our unit. No, we don't.
Thank you very much. Any other question from the panelists before we close?
Yes, sir. I'm Dr. Khalid from Afghanistan. Sir, I want to ask the respected panelists that kindly do tell us something about the radioactive substances they use, like bleomycin, phosphorus 32, yttrium 90. Do they have some experience here?
Okay, Dr. Tango or Dr. Gomi, any details about what sort of radioactive substance can be used in case of craniopharyngioma?
We use interferon. We don't use bleomycin. I mean, it's just to buy time until our children get bigger. That's the one agent we use, which is also currently, we are now starting to have limited access to it. So it's a concern for us. We don't use bleomycin, though we use interferon. Yeah.
So Dr. Gomi, in Japan, do you routinely give the radiation for any residual tumor, or what is the strategy in Japan?
I'm sorry, I can't.
For any residual tumor, what is the strategy you follow? Do you routinely give a radiation, or you wait, or what is the strategy?
Yeah, usually for the residual recurrent craniopharyngioma, we use the lipid surgery or radiation therapy. In some cases, we use proton therapy for the recurrent craniopharyngioma. I have a case completely controlled by the proton therapy for the recurrent craniopharyngioma.
Yes, definitely. Proton therapy is one of the very latest research in case of this pediatric brain tumor, especially craniopharyngioma. It does work wonderfully. Any other question? Yes, Dr. Masave, please go ahead. Unmute yourself and. You have to unmute yourself.
I'm a critical care nurse working in neuro ICU. I have come encountered with the infection to the most of the postoperative patient. Regarding the the VP shunt post-surgery, there is recurrent blockage and infection due to high protein. I would like any suggestion on how to tackle on that. Thank you.
So how do you prevent the shunt blockage? So you want to have any comments, Dr. Tango?
I wonder if Dr. Aaron wants to comment, because I think Dr. Laxwal Jaconia did a study on craniopharyngiomas and the cystic management with the Maya reservoirs. I think their infection rate was low. We're fortunate enough to not have a high infection rate also. So I'm not sure if maybe Dr. Aaron can also tackle that question in terms of what, since they've published on this.
Okay. Thank you, Anko. Yes, we did a publication on. We were wondering if there's some infection prevention effect with that fluid, because we also noticed a very low infection rate. Yeah. Thank you.
Okay, thank you. So what we do at our institute is, generally we don't do the ventriculostomy. We always do shunt. Okay, when we operate on the shunt, the next craniotomy will be after a few days. We don't immediately next day we do the surgery. You give the patient time, let the hydrocephalus subside. One thing. Second thing, whenever you're doing the shunt holes, they're very tiny. They're made for the CSF, and any proteinaceous substance is coming, they'll get blocked. So you manually, couple of holes, 2-3 holes, you make them big, so that even if any proteinaceous substance is coming, it may not get blocked. So that is the one thing. And second thing, we have recently, regularly we put Ommaya reservoir in the tumor bed cavity. But what we noted, it's very funny. Sometimes whenever the recurrence is happening, the Ommaya tip, sometimes it's within the cyst, sometimes it is outside the cyst. So that's just your luck. If it is within the cyst, you're lucky, you can ask for it and you can still buy a time. But if it is outside the cyst, then you may have to tap it again. Yes, thank you. Any other questions from the panelists before we close?
And I have an idea. If you have Ommaya implanted in the lesion, maybe you can test what kind of the component in the cyst. The cell, you can do the flow cytometry, or you can test the cytokine, the chemocytokine. Maybe this is the response to the radiotherapy. Very interesting. And
generally they are very, yes,
yeah?
Go ahead, please.
Yeah, please.
Go ahead.
Yeah, you can please.
So we've done some biochemical analysis. We found that they're very highly rich in cholesterol. That's why they're very proteinaceous, and that's why they're very oily, because of the cholesterol.
Yeah, it's oily. Yeah, but you can try to take some sample and test it.
Yes, thank you. Thank you very much.
Yeah, I want to discuss with Dr. Gomi about the medioblastoma cells metastasis in CNS. Sometimes if we elongation in the operation, the tumor cell will spread into the CNS system. Do you have any tips or idea about this?
Yeah, it's difficult. You correct the CSF from the, and you check the CSF for the dissemination or something like that. What did you mention? Yeah, I can get your comment. Yes.
I mean, in the operation, do you have any tips to prevent the tumor cell spread into the CNS?
Yeah, yeah. I have no idea to prevent CSF dissemination, but during surgery, we have to care the protect the tumor spreading around the
cotton.
But in the after surgery, we have no idea to not to prevent dissemination. So,
Yeah,
but,
regarding
in the dissemination, we use the methotrexate in intrathecal methotrexate. Sometimes it's effective via on my tube or something like that.
Yes. In our Xinhua Hospital, I was a pediatric neurosurgeon in Xinhua Hospital. We would like to implant the Omaya in every surgery for the medioblastoma.
Every?
Almost every.
Almost, yeah. We have no rare cases for the Omaya.
Maybe this depends on our different hobby. Yeah.
Okay. But it's possible. Yeah. Intrathecal therapy is almost it's also useful in some cases.
Yes. And regarding the medioblastoma, as I know, do you know Toronto, Michael Taylor? He's working in Toronto. Yeah, sick kids.
Yes.
Yeah. Several years ago, he published a paper about in Cell Journal. He verified the recurrent medioblastoma cell is from the blood. Interesting blood. Yeah, blood. Sometimes, mostly the medioblastoma recurrent from the CNSF spread metastatic tumor cell. But only some of case, the tumor will in the circulation, blood circulation out of the CNS system. So we think use the systematic chemotherapy is good to such cases. We have to kill the tumor cell in the circulation.
Yeah, I think it's good. Yes, systematic chemotherapy is also useful for that cases. Yes.
Okay.
Okay.
Yes, I can see two hand raised, Dr. Pirzad and Dr. Javed. Dr. Pirzad, you can go first.
Thank you very much. And I would like to draw your attention to you, Professor Kato, Chen, and other colleagues. And also I see Dr. Javed Khan. And I see that today we have a lot of Afghan young neurosurgeons, vigilants, to have them with us. And I like to draw your attention about pediatric neurosurgery in Afghanistan. This is also another challenge in Afghanistan. And in these times, we haven't pediatric neurosurgeon in Afghanistan. And we do some operation for the pediatric with our colleagues and the pediatric surgeons, and also some cases we do. The other neurosurgeon, the child that have pathology with like brain tumor and neurotrauma, craniosynostosis, hydrocephalus, spina bifida, meningoencephalitis cell, meningomyel cell. But unfortunately, we haven't trained pediatric neurosurgeon. I like to draw your attention. We have also, thank you for this support of ACNS Afghanistan Myanmar support. And also we have another group of Afghanistan initiative support that's we will discuss on it in this group as well. And likes to draw your attention that's for training and for the scale training of some young neurosurgeon for pediatric neurosurgery. And we need also the equipment and instruments as well. And then we establish a department or division of pediatric neurosurgery in Afghanistan. And also another good news that we integrate Afghanistan women in neurosurgery in Afghanistan. That's the starting point. Thank you very much.
Thank you. Thank you, Professor Pizzat. We are happy for your achievements and the work you're doing. Dr. Javed, you want to say something?
Yeah.
You can see your hand is raised. Yes, yes.
Thank you, Session. Thank you very much for
Yes.
excellent presentation. I'm coming back to the question of craniopharyngioma. It was excellent, excellent talk. Craniopharyngioma is being controversial for the past 80 years in terms of approaches. Mainly, I think, in terms of anatomy or in terms of pathology. I mean, in that case, been shown that in session, you also asked the questions. We do have here is basically mainly with adult, but with a pediatric, a little bit of basically case we do operate. But in that particular case, show, and if you look into anatomical location of that, so mostly, I mean, if you're looking from classification of craniopharyngioma, there'll be pre-infundibular, intrainfundibular, or retroinfundibular. So retroinfundibular a little bit behind. So I think this case was looking like a little bit of transinfundibular. So if the tumor is a little sit behind, I mean, if you go subfrontal, it will be not a little bit like difficult, challenging to go and just tackle the tumor. So from that, it's not compromising the operations and the recurrent rates. If you're looking the anatomical consideration into account.
Thank you. That's a valid question because the solid components, as you mentioned, the location. For us, the priority was to decompress the cyst, see if we can take away the cyst and take as much of the solid as possible. So the biggest bang for buck was going via subfrontal, but as we know that interoptic distance is very narrow. But which way would you have proposed? In a 11-year-old, we don't go transphenoidal, we don't go via the skull base. But I'm very interested to hear what approach you would suggest, Dr. Jawed, if you had tackled it.
No, mostly I think what we do, we don't have much more experience with the pediatric. We do with the adult, and we do have a really excellent base of skull surgeons, ENT. So we just mostly just take their help. We have expert opinion, but I just want to know like what's going with the pediatric.
Yeah, so with us going transphenoidal, the biggest thing is the cellar. So we do have transphenoidal adult surgeons actually, and along with ENT, the cases that they've done that on craniopharyngiomas, the cellar is very thickened and then CSF leak becomes quite a bit of a problem. So we tend not to do it, but we do have our adult team that does it more frequently, but in pediatrics, we do not often do it, but it'll be interesting to see if any of the other panel do in children.
Thank you.
Thank you. Thank you, Dr. Javed and Dr. Tango. Any other question or any point from the panelists or the speakers?
Yeah. Hi. Yeah. Hello,
yes, Dr. Chen, you want to say?
Yes, I think of my experience. One time we have a patient. Before operation, we think this is craniopharyngioma, but in my enhancement, there's no enhancement. So my feeling it is optical chiasma it's low glioma, and in operation, I was right. It was optical chiasma glioma. So I'm thinking we have to differ them before surgery. It's very dangerous if we cut or hurt the optical nerve. It's dangerous. Yes. Yeah.
Yes.
This idea. Yeah. I remember.
Yes. Thank you. Thank you.
Yeah, okay.
That's optico-hypothalamic gliomas. That's a very important. And sometimes if you don't do surgery, they do spread to the other side of the optic nerve also. So yes. Very interesting. Yes.
Yeah, but in that case, it looks very, very close, very similar. Yeah.
Yes. Thank you. Thank you very much. Thank you for your enthusiastic contribution.
Yeah.
So we have come at the end. I would request Dr. Liu, who's very quiet today, to say a few words at the end before we take a closing remark from Professor Yokokato.
Hello, thanks, Sachin. Actually, enjoying the discussion. I just hope member who attending today meeting. I wish to take 3 minutes of your time to show a promotional video, if you allow, on our upcoming autumn seminar, which we will schedule in November 20th and 21st. We going to have a long session for YNS presentation, and I hope all those attending today discussion will be able to submit your video presentation. And as usual, we have some form of competition, and there will be special award from our president, Professor Yoko Kato. If I'm allowed to share the video, Sachin.
Yes, please, boss. Please share.
Okay. So I'm going to share my screen. I lost the button, share screen button. One moment, Sachin.
No problem.
Because it's in.
You mute yourself. You need to unmute.
Yeah, sorry. One moment.
Okay, what I'll do is I'll make you co-host. Then you'll be able to do whatever.
Can I leave and join back because I lost the button?
You are co-host now. Do you still don't have the share button, or you've got it now?
Yeah, it is in. I couldn't see the shape the button with me.
Okay. Maybe you can quickly leave and come back again. Okay. Before the Liu comes back, I will take a final word as a moderator. I think we had an excellent session today. Thank you, Professor Akira Gomi, for the tips and tricks for the young neurosurgeon about the critical aspects of pediatric brain tumor surgery, and Professor Naoto Kundi for all the details about epilepsy surgeries with the diagrams and the videos. I'm sure we'll share your videos on our YouTube platform so that all the young neurosurgeons will benefit from it. And I would like to thank all the 4 moderators. Dr. Hira could not join today because of the time issue. Dr. Maruf, Dr. Lin, and Dr. Liu for thankful moderation today. Thank you very much. I would request Professor. Okay, I think Liu is able to share his screen. After this video, I would ask Professor Yoko Kato to say final remarks, please. Go ahead, Liu.
Do you hear the sound, Sachin?
We can hear the sound. Perfect.
I think YNS can get ready with your phone to capture the QR code for the competition, if possible.
Okay.
Thank you, Sachin.
Thank you, Marat, very much, Liu. That is an excellent video you have made. I think all the young neurosurgeon will be definitely excited to participate in the young neurosurgeon competition. Please, I request all of you to send your CVs and your paper for the competition. So before we close, I would ask Professor Yoko Kato to say final closing remarks and then.
Yes, but not final, but one lady neurosurgeon raise a hand. I do not recognize. Yes,
Hi.
please.
Hi.
Hi, how are you?
I'm good. How are you?
How are you?
I'm Dr. Yusra, a first-year resident here in Peshawar, in Pakistan, KPK. Yeah, and thank you for providing such a great opportunity to learn different stuff here.
I would just like to introduce Dr. Yusra. Professor Yoko Kato, Professor Tariq Khan from Pakistan has recommended Dr. Yusra as a good young neurosurgeon, lady young neurosurgeon from Pakistan. So she's quite helpful and she's helping a lot. So thank you very much. Welcome, Dr. Yusra.
Thank you, Dr. Sachin. Thank you, Dr. Professor.
Yes, please continue. Continue to join us, please. Can you continue? Please.
Yes. I've watched a few sessions and they're really great and helpful in learning. And actually, through these sessions, I'm able to explore new subfields and like to learn about new things like the epilepsy surgery. It does not happen here around us, and this is something I'm going to learn about now.
Mm-hmm. Okay, just maybe Dr. Kuni is still here.
Yes.
Please, can some points to Harvey. She wants to learn.
Yeah, thank you.
I'm really interested in it.
Yeah, thank you very much. As I've shown, epilepsy surgery is not technically difficult, but the difficult point is the diagnosis of epileptic focus. You need to use various kinds of modalities like MRI and FDG PET or something more. But I think, for example, corpus callosotomy, as I introduced, is maybe very useful for patients who drops by seizures, who frequently falls. I think corpus callosotomy is very useful for those patients in your country. Yeah, thank you very much.
Okay, and what would be the post-surgical complication, if you can share, like post-callosotomy?
Yeah, if you cut the whole corpus callosum, the patients will experience mutism in acute stage after surgery. This acute kind of complication is relatively frequent. But if you do this surgery, younger patients, it's very rare that the patients will develop permanent deficit.
Thank you. So, Dr. Tango, you want to say something?
No, Prof, not at all. It was thanks for the invitation, and I learned a lot. So I look forward to joining in more. Thank you.
Okay. So the Professor Kuni is when he was young, he was very good stroke neurosurgeon, but slowly shift to the epileptic neurosurgeon. He's excellent neurosurgeon, I think. So today's we have very nice the lectures and also the comment, and also especially the Professor Prasad. Thank you very much, bringing so many young neurosurgeons from Afghanistan. I think the condition of the society is a little bit, I think, settlement Is it correct? So I think in the future we can continue the support to your country in education. We can get more the female neurosurgeon of the Pakistan or South Africa, and also the Maruf today is you are very quiet, Dr. Maruf from Uzbekistan. Are you with us now?
Yes. Good evening, Professor.
Please say something, because just so you can say short introduction of the doctors, please.
I am very grateful for this chance, and it's honor to be part of today's event. There was interesting presentations, and I think we learned many things, new knowledge, and from epilepsy surgery also. And nowadays, also our government interesting for this field of neurosurgery, and we are starting to do some epilepsy surgeries, and also we are going to do some DBS surgeries. Maybe some colleagues will go to Japan and some places to study this surgery also.
Thank you very much. But because you have some annual meeting, the Uzbekistan annual meeting.
Yes, next month.
Maybe you can invite all young neurosurgeons, I think.
Okay, I will inform you and mail all of them.
Okay,
thank you
so much.
Sensei.
Thank you. And Professor Gomi is a really expert of the pediatric neurosurgeon. So recently, gradually, we are getting more and more the endoscopic treatments, because it's very less invasive, even the posterior fossa, I think. So maybe that's tonight, Professor Gomi, he did not mention about that, but I think one of the technology is minimally invasive and less invasive for the patient, I think. But anyway, the great lectures from the three doctors, and also the MC, tonight MC. Thank you very much for a nice introduction and MC. And finally, Sachin and Dr. Liu, the two of them is just very important for YNS committee, I think. They are driving force of the committee. So thank you very much for a nice organization of tonight. No, I don't know. Maybe your place is not night. Japan is almost 10 o'clock p.m. So thank you so much.
Thank you.
Thank you so much.
Thank you, Professor, for the kind words. You are the energy for all our driving force. So thank you for supporting and encouraging us. Thank you.
Thank you so much.
Thank you.
We'll see you again.
Thank you all. Bye bye.
Thank you again,
Bye-bye.
Professor.
Thank you.
Bye.
Thank you.
Thank you. Thank you.
Thank you.
Thank you. Thank you. Arigato. Arigato gozaimasu.
Arigato.
Thank you very much. Bye.
See you.
Bye-bye.
Bye.
Arigatou
Bye.
gozaimasu.
Thank you very much for a nice explanation. So you studied a lot. Thank you.
Thank you. Thank you.
Thank you.
Bye.
Thank you, Dr. Aaron. Thank you. Thank you. Sure. Thank you, Dr. Maruf. Good job.
Thank you. Thank you so much.
Thank you, Dr. Hemanta. Thank you, Professor Pirzad.
Welcome. That's you remember about our short training program, and
I do remember, but
make this point that's about pediatric neurosurgery, and that's good to see Dr. Maruf Salam. And we are neighbor, and we would like to have a good communication with you, and but Uzbek neurosurgeons.
Okay. Okay,
We all are neighbors.
Okay. Sachin, could you please share Dr. Maruf email address with me as well?
Yes, I'll send you. Oh,
okay.
I'll send you. Yes.
Okay. Thank you.
Thank you very much for coming and joining. Thank you.
Bye.
Bye.